All right, so I think we'll get started here. All right, so there's plenty of examples of dynamic duos out there in the world and pop culture, and oftentimes there's a main character and an unsung hero sidekick that often gets underappreciated. And in today's talk, I'm hoping to convince you that this dynamic duo is among the most important. And the image on the left is the image of angiography that we're most familiar with and often gets all the fame. But the image on the right, the venous phase of an angiogram, is what I argue is an unsung hero in cerebrovascular and not fully appreciated. But today I hope to convince you that the image on the right is just as important as the image on the left. So as I said, this is the image of angiography, cerebral angiography that we're familiar with, a simple AP and lateral arterial phase angiogram. And this is the anatomy that we know. This is the image of the glamorous AVM and artery and aneurysm treatments that we're familiar with. But if you just wait a few seconds later in an angiogram, this is what you'll see. And this is an image that most of us aren't too familiar with. But in the venous phase, there is so much to be appreciated. There's interesting anatomy and oftentimes fascinating interventions that are as interesting as the arterial side. So here's a little layout of what we'll be doing today. I'll start off with some anatomy and embryology. We'll go into some basics of the technical side of venous angiography. We'll talk about some venous pathologies that I think are most interesting and highlight why I think venous anatomy is fascinating. And finally, we'll go through some cases that hopefully will encourage you to appreciate the veins as much as I do. So starting with some anatomy, we'll quickly, let's see, Long, do you mind just helping us out here? You there?
Yeah, Silva, I'm here.
All right, so I'll just go through a couple arrows just to give everybody kind of a basic framework to start thinking about the anatomy. You see that blue arrow there? I'll go through a couple of these. You can just shout out what the arrow is pointing at.
Yeah, so that's superior sagittal sinus.
Good, and then moving down here.
That's confluence of sinuses.
Yeah, torcula, exactly.
Transverse sinus. Sigmoid, or transverse sigmoid junction.
Perfect.
Sigmoid sinus.
Great.
I think that is
so large cortical vein, temporal lobe.
I think that's is that the basal vein of Rosenthal?
So this is a superficial vein. The AP here on the left helps you. You can see it's superficial. So it's be inferior anastomotic vein or vein of Lebet. All right, so now we're getting to what you were wanting to talk about, which is the deep venous system. And it's important to differentiate superficial from deep, which is why I've laid it out this way. So you want to go through maybe from like top left to bottom right of those green arrows for me?
Yeah, so top left, let's see. Top left, I think that is internal cerebral vein going
Correct.
into the vein of Galen, and then top left, sorry, to bottom right, yeah. So internal cerebral vein going into vein of Galen, which drains into straight sinus, and then the last one would be the basal vein of Rosenthal.
Perfect. So that's kind of a very simplified way of thinking about the veins, but it is important to think about the superficial versus the deep system. This matters both for interventions. It matters for understanding symptoms related to venous pathologies, and we'll go into detail much more deeply further on. But just kind of as a framework to think about it, it is important to split up the venous anatomy into superficial and deep. So not only is angiography important, not only is the anatomy and the physical anatomy of the arteries and the veins important in angiography, but angiograms are dynamic images, and the time at which the image is taken or the time at which you're seeing the contrast go through the arteries and the veins is critical. And for the veins, it's just as important as the arteries. So these images, these are paired images, top and bottom, and they're all technically Venus phase images, but taken at different times in the Venus phase. So these are out of order. Turkey, do you want to help us out and reorder them correctly? Who else is here? Damien, can you help us out?
I'm here, but for whatever reason, I can't see the images. So I don't think they're loading my phone
All right.
properly. Sorry.
No worries. No worries. So basically, correct order of these images is the first image, the earliest Venus phase is all the way on the right. Then the second one is on the left, and the third is in the middle. So if we reorder these, this is the correct sequence of images, and it is important to think about all the different Venus phases, and this will be important as we move later on in the discussion. So in the early phase, this highlights the superficial cortical veins. This is a phase when you'll see high flow shunts. Think of like a high flow AVM. You'll even see veins obviously in the arterial phase, but this is in terms of the venous phase where you would see high flow shunting. The mid phase, this is kind of in an intermediate phase where you see both the superficial and the deep veins, as well as the dural sinuses, kind of a good overview of everything. And lastly, the late phase, this is best for the sinuses, as well as late draining tributaries. Think of the deep system, as well as developmental venous anomalies would show up in the late phase. So I'll briefly touch on embryology. It is important to think about embryology because it does affect how, a lot of the pathologies that we treat as well. You can think of the venous system as developing from brain demand. So for instance, initially the telencephalon isn't fully developed, of course, and so you don't necessarily have a huge superior sagittal sinus. There's the main vein that you can see here is what's called the primitive marginal sinus. It's that green arrow, and superior to that, you see in pink this early sagittal plexus. But it over time, as the brain develops, and more brain means more venous drainage, the sagittal plexus then coalesces to form what we know as the superior sagittal sinus. And these are the origins of the superficial venous system. Even as early here as 48 days, you see an early transverse and sigmoid junction as well. Now, in terms of the deep venous system, this develops a little bit differently, but similar principles based on demand. So what's this vein called the vein of Markowski drains the choroid plexus, which is one of the earliest producers of venous outflow in the developing fetus. And this then drains into the developing superior sagittal sinus. Now, as the internal cerebral veins develop due to the, as the brain develops itself, this plugs into the vein of Markowski, and ultimately posterior part becomes the vein of Galen, and the anterior part regresses. So again, this is all in flux and true of basically all of embryology, but you can think of it over the course of embryology as demand increases for venous outflow. The anatomy that we know today, that we know in the adult, gradually appears. So by the 11 weeks, the venous anatomy looks remarkably similar to what we're familiar with in adults. So, most of the people in the audience probably aren't doing cerebrovascular or don't have a particular interest up front in venous angiography. But I would argue that in all of cerebrovascular, perhaps the most relevant to other parts of neurosurgery is venous angiography. And venous pathologies tend to affect so many areas of neurosurgery. So all of these images, whether you're a neuro-oncologist, a spine surgeon, an ophthalmologist, whatever it may be, it's likely that you'll cross paths with some sort of venous pathology, and oftentimes even more than arterial pathologies in cerebrovascular. So here we go. We'll talk about some cases, and hopefully this will convince you that the veins are truly important. So this is a 65-year-old female. She presents with 1 month of right eye redness and swelling. Her ophthalmologist thought maybe it's an infection. They tried antibiotics, it didn't work. You can see the image of her right eye there, mildly proptotic. She has elevated intraocular pressures, and on fundal exam, they noticed dilated veins, and as well as some dilated scleral vessels. Her vision not significantly affected, but the pressure is definitely elevated. So here on this, this is an MRI here on the right and left. You can see in the right eye, there's this large vascular structure. And we'll see in the angiogram later what it is, but clearly the right eye is proptotic, and there's this large vascular structure in the superior aspect of the globe, the orbit rather. So this is an ECA, external carotid artery injection. As you can see, we have early filling of a venous structure here. Even in the arterial phase, you're seeing venous filling here of the superior ophthalmic vein. And this is the AP image of that as well. Now we have an internal, now we have an ICA injection also showing early venous filling. In this case, you're seeing early filling of the cavernous sinus. So the diagnosis here is just a pretty classic image of a carotid cavernous fistula. So there's different ways to think about carotid cavernous fistulas, and the details of the grading systems aren't necessarily important to memorize, but the principles are important. So the way to conceptualize these fistulas are basically whether it's direct or indirect, meaning direct being literally a hole in the carotid and the ICA that drains into the cavernous sinus. So you get high flow, direct flow arterial into the cavernous sinus. And this is the most common of the carotid cavernous fistulas. You can see this with trauma, or for instance, a ruptured cavernous aneurysm of the ICA that then pours arterial blood into the cavernous sinus. These are obviously the highest flow. Then there's indirect, which arises from dural branches, either from the ICA or from the ECA, that then drain into the cavernous sinus in a low flow fashion. From the ICA, these tend to be from the meningohypophyseal trunk. From the ECA, usually the imax, sometimes middle meningeal. These are lower flow, right? It's not a direct connection between the artery and the cavernous sinus. It's through these smaller feeders. And then the other way to think about it is whether they're from the ICA or the ECA or some combination of those two. So that's where this grading system comes from. Again, the details aren't important, but it's more how you conceptualize the classification. So in this case, this is a type D, meaning it's indirect, lower flow from small feeders from the ICA and the ECA. So this case is all about the cavernous sinus. It's important to understand the anatomy, and it's important to understand the inflow and the outflow of the cavernous sinus. That matters for the symptomatology, how severe the symptoms are, and how to treat it. We'll come back to this image many times, but just think about this AP image of the cavernous sinus and trying to burn it in your mind. So here's a schematic looking at the draining tributaries into the cavernous sinus as well as the outflow. And the interesting thing about the venous system is obviously it's very low pressure. And when the cavernous sinus sees arterial blood and the veins see arterial blood and arterial pressures, the natural response is to thrombose, arterialize, and slowly these draining veins out of the cavernous sinus can thrombose. And that is a vicious cycle because that just means that there's less venous outflow and you get more pressure in the cavernous sinus and fewer places for it to go. And you can recall from that angiogram that I showed you on this patient, you really didn't see much anterograde venous drainage. All of that most of that venous outflow was going into the eye, which is why the patient presented with her symptoms. And like I said, it's a vicious cycle. The process accelerates as more and more outflow gets closed off. So it's a dynamic system, and oftentimes the symptoms become most prominent when more pressure gets sent to the eye. So back to this image. So we know the issue. You have excess arterial drainage into the cavernous sinus, and now we have to think about the anatomy and how we're gonna address this. So usually the simplest way to treat these, and there are exceptions, the simplest way to think about it is to block the venous side of the fistula. So there's arterial inflow into the cavernous sinus. You have to find where that inflow is and close it off in a simplistic explanation. And the interface between that fistulous point and the cavernous sinus is critical. So thinking about that, how do we get into the cavernous sinus? The bottom line is we have to get in there somehow. And it turns out that the inferior petrosal sinus here tends to be typically the easiest way to access the cavernous sinus and treat these fistulas. So back to this image, you can see here accessing the IPS comes from the internal jugular vein, and it tends to be, in most cases, the most favorable anatomy to get into the cavernous sinus with the least issues. And typically it points your catheters towards the eye, the ophthalmic veins, which is useful for treatment, which we'll talk about in a second. It's often the easiest route, but it's often closed off, and there wasn't a clear inferior petrosal sinus in the injections that I showed you. Now, that doesn't mean you still can't use the IPS, but it requires a little bit more of a challenge in trying to bore through it if it's occluded. So in this case, that was attempted, and sure enough, we got to the inferior petrosal sinus and into the cavernous sinus. But being in the cavernous sinus isn't enough, right? We have to get to the fistulous point, and even more important, we have to protect the eye. So you can imagine if you occlude, if you fill up the cavernous sinus with coils, but the eye is still left unprotected and there's still a fistula, that just means that there's less venous outflow from the cavernous sinus and even more pressure into the eye. So if you don't get to the fistulous point, if you don't get to the ophthalmic veins, the veins draining into the eye, then you may make the problem worse. So here we got into the cavernous sinus, but couldn't quite get to where we needed to go. And you may think, well, I mean, the hard part seems to be getting into the cavernous sinus. And in those schematics, sometimes it looks like a nice blue oval, but in reality, this is what the cavernous sinus looks like. Trabeculated, tons of septations, often very difficult to traverse and get to the place in the cavernous sinus where you need to go. So this is a common issue. And in this case, it was unsuccessful. So there are many creative ways to get into the cavernous sinus, to get into the vein. And I won't go through all of them, but in this case, as we saw, the prominent venous outflow into the eye meant directly accessing that vein turned out to be the best option. So how do we do that? Here on the left, you see kind of a 3D reconstruction of the angiogram as well as the skull. And on the right, you have a native image of the case of the intraoperative fluoroscopy. The important thing is to line up the vein in clearly to be accessed with the needle, and make sure that it's obviously separate from the optic canal. And so you want the optic canal, in this case, it's superior medial, and you can line up the vein so that you can access it directly under direct fluoroscopic guidance. On the lateral, it's also important to know your depth, because what's right past your needle is the carotid. So so the 3D recons are very helpful here. And so here on the right, you saw previously, this is the needle accessing the vein. Once you get venous return, this is where you can thread your microsystem into that vein. And so instead of going all that route through the IPS into the cavernous sinus, in this case, that catheter goes directly inferior to the globe here and into the vein. So in this case, the coiling was done, think about in almost reverse fashion, reverse direction from the other way. If you think about that sagittal image I showed you before, if you're going through the IPS, you want to make sure you protect the eye, coil off that venous outflow into the eye, and then make sure you coil back into the fistulous point and make sure you block that. Here, you can block the fistulous point and then coil back and close off and protect the eye. So this is what you see here in the yellow circles, the coil mass, clearly separate, not in the ICA, and blocking off the fistulous connection. Here are the post-op images with no residual. And this patient did great, had complete resolution of her symptoms. So some takeaway points. That was a particularly challenging case, but sometimes they're more straightforward to the IPS. But whether it's a simple or a complicated case, the important things to think about when it comes to CC fistulas are whether they're direct or indirect, and whether they're fed by the ICA or ECA. And again, this factors into the progression of symptoms as well as the treatment options. It's important to clarify the venous anatomy. Every patient is different in terms of how the venous anatomy has adapted to that high flow arterial blood into the cavernous sinus. And you want to find the best path to the fistulous point in the cavernous sinus. So that can be either, like I said, through the IPS, which is typically how it's done, or a number of different creative ways to get there. And as in this case, direct cannulation of the vein can be an option. So moving along, this is another case of a 29-year-old gentleman who presented with pulsatile tinnitus on the left side, exacerbated by exercise. He had a full non-invasive workup with a CTA, really mostly unremarkable. The radiologists were concerned for possible compression of the left jugular vein. no one really knew what was going on. So he was referred for a diagnostic angiogram as well as venous manometry to take a look, to measure, to assess for elevated intracranial pressure. So this is what our angiogram shows. As you can see, there's venous sinuses appearing in the arterial phase. So clearly something is awry here. And if we zoom in a little bit more, we have a nice view of the normal and abnormal anatomy. So you have the anterocoroidal, most distally here, you have in the green area, the posterior communicating artery. And in the red arrow, this is the meningohypophyseal trunk, which oftentimes is very small. This is abnormally prominent. Sometimes you would have a hard time actually seeing it. And this is plugging into the transverse sigmoid junction here in the gold arrow there. So here, moving along, we'll go to a schematic here of the meningohypophyseal trunk. Again, it's anatomy that we don't often see too clearly because it's not too prominent, but this is a nice diagram which overlays the arterial anatomy with the veins as well as the intracranial anatomy. So you can see in the letter B here, this is the lateral tentorial artery. This is indeed the one that we were seeing before, plugging in here abnormally into the transverse sigmoid junction in this area. Other branches of the meningohypophyseal trunk, which aren't relevant for this case, but are important to know. You have the marginal tentorial artery, which is here, which you can see on the leading edge of the tentorium, often associated with large meningiomas and things like that. You also have the inferior hypophyseal artery here, and some other branches which we won't go into. But the cool thing about angiography is you look at this image and you have to, in your mind, overlay it with this image and think about where everything is in relation to each other. So what else do we want to see? Well, we want to see an external carotid artery injection as well. And sure enough, there's significant contributions to this fistula from the ECA. Play that again. So here is a nice image, schematic on the left and our angiogram on the right. Here you have middle meningeal artery supply to the fistula's point. And the MMA is, there are several branches of the MMA, and it can be variable in different patients, but it's important to understand which branches are high risk and not totally relevant for how we treated this case, but relevant for many treatments using the MMA. So that this branch here, you're seeing the petrosquamosal MMA. However, here in the back, this is the petrosal branch, which is worrisome for any sort of embolization because you have branches that supply the facial nerve, and embolizing this artery puts the facial nerve at risk. So here's a 3D spin of this to give you a better sense of the spatial anatomy. Very clearly, MMA supply to this fistulous point at the transverse sigmoid junction. So that was the arterial side. Now let's focus on the venous anatomy. So this is clearly abnormal. First of all, we're seeing veins during the arterial phase. And not only that, this should never be seen in a normal venous outflow. So you're seeing this sort of pocket of venous blood in this is the transverse sigmoid junction right around here. And the sigmoid sinus really isn't draining anterograde. There's this pocket here and you're getting reflux across the transverse sinus going to the other side, clearly abnormal. And what's happened here is because of the high arterial blood, just like we talked about with the cavernous sinus and the CC fistulas, this vein has arterialized, thrombosed, clotted off, and you're getting reflux back to the venous side, to the contralateral side. So broadly, dural arteriovenous fistulas, they can be idiopathic or acquired. The symptoms of these fistulas are entirely related to the venous drainage. So oftentimes patients will present with pulsatile tinnitus, which is in fact what this patient presented with. And this is thought to be due to the high flow, the arterial flow through the dural sinuses. You can get ophthalmologic symptoms or cranial nerve deficits, depending on other patterns of venous drainage. But the issue here is with the veins. And we always talk about hemorrhage risk with fistulas, but that's specifically if cortical veins are involved. And if cortical veins are not involved, the hemorrhage risk is exceedingly low. And we'll talk about that a little bit more. So again, we're back to classification systems, but it's less about memorizing the classification system and more about understanding why people think about fistulas this way. So type 1, these are the lowest risk lesions. You can think about arterial blood dumping through the fistula into a sinus, and draining anterograde. These have a very low risk of hemorrhage and tend to have a low risk of converting to a higher lesion, although they can. And in this case, again, the arterial blood is flowing in the correct direction in the vein. You're not having any reflux into the upstream veins, and you're not having any reflux into the cortical veins, which means that you don't have that hemorrhage risk that we talked about. So type 2 and 3 lesions, these are the lesions where the cortical veins are at risk and you have a hemorrhage risk, because these are delicate veins that can then bleed intracranially. The symptoms here tend to be from venous hypertension, and like I said, the biggest thing that we worry about is hemorrhage, and this is why these are often treated. So another element to this is the symptomatology. People have figured out that if patients are asymptomatic, even with higher risk angiographic fistulas, that carries with it a higher risk of hemorrhage or neurologic deficit. So the differences are right around 1.5% versus around 7.5% of hemorrhage, whether it's type 2 or 3, whether or not the patient has symptoms. And the symptoms specifically are symptoms of venous hypertension and subsequent cerebral ischemia is how they spin it. Not tinnitus, not other symptoms. So it has to be venous hypertension. So important to keep that in mind. Yet another classification here, this is the Cognard system, which a lot of people will use. Just important to know that it's the same principles. The differences are anterograde versus retrograde flow through the sinus, and then whether or not there's backflow into the cortical veins. Again, that's where the hemorrhage risk comes from. So back to our patient, this is the angiogram again. The key here, again, similar to the CC fistula, how do we get to the fistulous point? How do we close it off? And similarly, why is the treatment of closing off the venous side of this fistula, why is it not like an AVM? Why doesn't this rupture like an AVM if you close off the venous outflow? One way to think about these fistulas is they're AVMs within the dura. So even if you close off the venous outflow, they're not going to rupture into the brain parenchyma like an AVM. So the key here is treating the fistula by occluding the venous outflow and the venous side of the fistula's point. So in this case, how do we get there? We talked about how this vein is occluded. The anterograde drainage through the sigmoid sinus and the jugular is occluded. So we have to get to it from the other side. So let's step back and talk about venous access. Typically, we go through the femoral vein. This is a large vein, easy to access and easy to bring a large system up. But sometimes we don't need super large systems. And anytime we get femoral access, there are risks associated with hemorrhage and limb issues. So recently, we've started to find other ways to get venous access. We've been using the arm a lot more. So this is a schematic of the venous anatomy of the arm, and there's many options for accessing the veins and doing everything from diagnostic to interventional procedures through the veins of the arm. We often use the proximal basilic vein, or in some cases, if it's large enough, we'll use the distal basilic vein. So literally just a small puncture in the wrist, very comfortable for patients and avoid some complications associated with femoral access. So for that, and for this patient, we prep the patient like this, an outstretched arm. And this is a quick video showing us getting venous access into the distal arm, placing the sheath, which ends up being next to the arterial sheath as well. And this is the image you get when you do the run, venous access distal in the basilic vein and easy access up to the proximal basilic vein. And the veins, just like the arteries, are just a series of highways. You can get, in theory, anywhere from anywhere in the body. So once we get up into the subclavian vein, the key is accessing the internal jugular, depending on which side. And this is the anatomy of the neck, of the veins of the neck, showing you can get to either side from the arm or the leg. So back to our venous image of the fistula. Here you can see, like I said, can't come from the ipsilateral side, have to come contralaterally. This is the microcatheter and micro wire coming across the venous side on the transverse sinus across from the other side. There's a native image of the wire. The key here is getting to the fistulous point, as I said. And here we can see a run showing that the catheter is in the appropriate position right at the fistulous point. And this is the specific point that needs to be occluded in order to close the fistula. And long story short, throw a bunch of coils in, occlude the fistula, and occlude the whole venous outflow. And no residual on follow-up runs. This patient did great, resolution of his headaches, tinnitus, and that was, as I said, a higher risk fistula because of the retrograde flow and the cortical venous reflux. So had a risk of hemorrhage, and like I said, the patient did quite well. So again, stepping back, thinking about dural AV fistulas, the key is classifying the fistula, understanding and stratifying the risk, and symptomatology matters. It's not just the angiographic appearance, symptomatology does matter as well. In terms of treatment, you need to identify very clearly the fistulous point, even though there may be tons of arterial supply. Most often that leads to a single fistulous point. And once you identify that, you can identify the optimal path to embolize that. And lastly, transvenous embolization, while typically done through the leg, more recently we've started to do that through the arm, and that's very feasible in many patients. All right, we'll move on to another case. So this is a 72-year-old, history of papilledema since 2016. Initially back then presented with a year of gradual blurring of his vision and had an LP showing a opening pressure of 24. These are his images from 2016, grade 2 papilledema. At that time had full visual fields. And this was mostly affecting the left eye. Lost to follow-up. 6 years later, he shows up. He stopped the Diamox, wasn't tolerating it, and presents with worsening vision in the left eye, as well as slightly worsening vision in the right eye as well. The papilledema at this point has progressed. You can see here, this is 6 years later. The eyes are significantly worse. Classic story of IIH. So idiopathic intracranial hypertension. This is typically managed non-invasively, and this happens before these patients even get to neurosurgery. The mainstay of treatment is weight loss, as well as carbonic anhydrase inhibitors. There's a classic trial called the Nordic trial, which showed that Diamox, in addition to weight loss, improved visual fields more than weight loss alone. And this is typically managed by the ophthalmologist and the neurologist, but there are always patients who fail that. So many patients struggle with the side effects of Diamox, and intolerance is quite common. There's also recurrence, whether or not it's related to medication compliance. Oftentimes, the non-invasive treatment fails. So invasive options, and when they often show up to us, is when they may need CSF diversion. Other surgical options managed by the ophthalmologist is optic nerve sheath fenestration. And more recently, venous stenting has come up as an option for these patients. And that's what I want to talk about today. So here's the MRA of the patient that we just talked about. You can see very significant transverse sinus stenosis, especially on the left there. You can see, so this is a patient that we think may benefit from venous stenting based on the data that's out there. And I'll go through that a little bit. And basically the key here is clear diagnosis of IIH, evidence of stenosis on the MRV, and these are patients who recently folks have started considering for venous stenting. So the data out there is growing, and we're not quite there yet with definitive randomized controlled trials, for instance, but this is what mostly retrospective data has shown. Papilledema improved in 94%, other symptomatic improvement also with good benefits, and a low rate of recurrence. Again, these are pulled from different studies, but at least similar, in some cases better than CSF diversion. So how do we predict who will benefit? This is where a lot of the research has been, and this is what most of our patient care is based off of. So this is back to the patient we talked about. These are oblique images of the sinuses to highlight the stenosis, which you can very clearly see on both images. What we do here is we start with what's called venous manometry. Basically, it's a simple way to measure the pressures throughout the venous system and identify whether the venous stent may be of benefit to them. The key here is you want to identify the dominant side of drainage. That's typically the side that they would benefit most from venous stenting. If they're dependent, for instance, on the right side and they have very significant stenosis there, opening that up with a stent is most likely to benefit them. So how do we do the venous manometry? We take a small catheter up through the sinuses into the superior sagittal sinus and hook it up to literally an ICP monitor and measure the pressure. So as you can see in this patient, clearly elevated 25, 21, 26 in the superior sagittal sinus down to the torcula and the medial transverse sinus there. And immediately across that area of stenosis, the pressure drops from 26 to 6. So this venous manometry is very informative because it tells you that that stenosis may be contributing to their elevated pressures. And this is how groups have been selecting patients for venous stenting. And there's good data to support this. Higher pressure gradients across the area of stenosis are associated with favorable outcome after stenting, and favorable outcome meaning improved or completely resolved vision. There's some new data out there suggesting that even with low pressure gradients, people may benefit, but at least in the practice here at Jackson, we select for patients who have a significant gradient across that stenosis. The numbers that are used around 2021 as a cutoff for patients who tend to do well from venous stenting. Again, this data is growing as we speak. And clearly change in pressure gradient is independently associated with favorable outcome after stenting. So how do we do this? Again, this is the same patient. You see the stenosis of the transverse sinus. We bring a microcatheter up into the superior sagittal sinus. We do an injection to make sure that we're in the sinus and on some small cortical vein, for instance. We bring our guide catheter, the big catheter up that we'll use to support the stent. And we deploy the stent across the area of stenosis, as you can see there. And here's the post-stent image, which clearly angiographically shows a dramatic improvement in the stenosis of the transverse sinus. So a fairly straightforward procedure, clear angiographic improvement afterwards. This patient did super well, off Diamox, papilledema totally resolved, and his vision is basically back to normal. So with good patient selection and the right patients, this is a very useful procedure and is becoming more and more popular, certainly avoids the issues that we're all familiar with shunts. And hopefully we get more data that helps us even better select for the best patients who would benefit from the procedure. So I want to briefly talk about two other less common things that we do with the veins. And again, less commonly seen, but important to know about. So cerebral sinus thrombosis. These patients rarely even show up to our door, but it's important to understand the steps that occur before they get to us. So this, for instance, this patient, a young female who woke up with left-sided weakness, no other past medical history. As you can see, a small right frontal hemorrhage, and the MRV here shows a obvious thrombosis of the superior sagittal sinus. Treatment for this, anticoagulation. That is the mainstay, regardless of whether or not there is hemorrhage. This is the classic board's question, but even with hemorrhage in this patient, anticoagulation is the treatment, and making sure that they're therapeutic on that anticoagulation is critical. So this patient started on anticoagulation, 24 hours later, getting worse. And it's not related to hemorrhage, getting worse. Venous hypertension, the venous congestion is progressing, now has dense left-sided plegia, worsening mental status and seizures. And the workup actually showed that she has a hypercoagulable mutation. So at this point, they call neuro-IR, and the treatment in this case with failed anticoagulation, a failed good course of anticoagulation with a worsening exam. These are the very rare selective patients who go for a thrombectomy. So we do thrombectomies all the time for arterial side strokes, but these are venous thromboses that rarely come to our doorstep and need a thrombectomy. The important thing here is you don't need a perfect result. Some sort of partial recanalization can be very, very effective at allowing for the clot to then dissipate. In this case, you can see this in the middle image, the microcatheter past the clot and showing obvious thrombosis of the sinus. These are very large veins, obviously, and we really don't have aspiration systems and thrombectomy systems designed for veins this big. And so often with multiple passes, we can at least get some partial recanalization. And we often leave a microcatheter in the sinus to infuse TPA. Like I said, you don't need a perfect angiographic result. In this patient, the sinus reopened after the course of intravenous TPA through that microcatheter and the thrombectomy, and returned to nearly their neurologic baseline. So the takeaways for cerebral sinus thrombosis commonly affects young and middle-aged females. The primary treatment is anticoagulation. Absolutely 100% anticoagulation, even if there is evidence of hemorrhage on the CT. However, patients who fail anticoagulation or worsen clinically despite the anticoagulation are candidates for venous thrombectomy. Important to keep in mind that, of course, as the venous congestion progresses, that hemicraniectomy has to also be considered. So there's a schematic of what I said. And the data for mechanical thrombectomy is fairly good. Again, complete recanalization isn't the goal. Even partial recanalization can promote the subsequent thrombolysis, especially with that adjuvant intravenous TPA through the microcatheter. 76 to 84% rate of good outcome after thrombectomy, and a relatively low rate of recurrence. Most of this is retrospective data. About 10% rate of increased or new hemorrhage as well. And lastly, I want to talk about inferior petrosal sinus sampling. This is another procedure that we do, which very much crosses paths with other areas of neurosurgery. So we're familiar with Cushing syndrome and the classic phenotype of rounding of the face, weight gain, muscle loss, fatigue, mood disorders. It's a very clear clinical diagnosis that usually gets worked up through endocrinology and ultimately sent our way depending on what's found. So this is the hypothalamic axis responsible for cortisol production. And it's important to think back to step one and remember this in order to think about these patients. So what are elevated? The issue with Cushing's disease is, of course, elevated cortisol. Many different sources of elevated cortisol. This could be exogenous cortisol taken, for instance, patients on long-term prednisone use. There could be paraneoplastic hypercortisolism from ACTH production of, for instance, small cell lung cancer or renal cell carcinoma. Those are the two most common culprits. All of these can lead to elevated cortisol. But sometimes, and these are the patients that usually show up to us, the source is the pituitary gland. So these are patients who require further testing to decipher whether it's a peripheral or a central source of elevated cortisol. So the classic tests are the low dose and high dose dexamethasone suppression tests. So if you think back to the physiology here, at a low dose of steroids, whether the source is peripheral or pituitary adenoma producing this, typically the cortisol will remain elevated. So low dose, typically the cortisol is persistently elevated. However, if you give enough dexamethasone, the pituitary is still subject to the same negative feedback as the pituitary adenoma is still subject to the same negative feedback as the pituitary gland. So you would expect the ACTH to drop in those cases. Whereas if it's a peripheral source not subject to negative feedback, you'd have persistently high cortisol. So some cases, it's not that clear and they need even further workup, whether it's an equivocal result or otherwise. It's important to, these patients often come to our, come for an IPSS. There are two purposes. One is to localize the source of excessive ACTH to the pituitary gland. And then in some cases, even if it's thought to come from the pituitary gland, these tumors may be small and not, and in order for surgical planning, lateralizing the side of the tumor can be important for preoperatively. So back to our role and the veins, the hypophyseal veins drain into the cavernous sinus, which then drain into the inferior petrosal sinus. So if you give desmopressin or corticotropin releasing hormone, that would typically stimulate ACTH production in a normal pituitary as well as in a pituitary adenoma. And the key here is that both sides of the pituitary drain into each inferior petrosal sinus. And by measuring the ACTH in both sides, you can decipher which side the tumor is more likely located on. And again, just detecting excess ACTH production can localize the source to the pituitary gland. So we're back to our favorite image here. This is what we're looking for. We talked about the inferior petrosal sinus before. As I said, it drains the cavernous sinus, therefore drains the pituitary outflow. Therefore, you can pick up the elevated ACTH production. So this is how you interpret it. These are how the results are. You basically, after placing the catheter in each inferior petrosal sinus, you deliver the corticotropin releasing hormone or desmopressin. They both have the same effect, and measure the ACTH in bilateral IPSs normalized to other pituitary hormones to make sure that it's not a dilution problem. and you measure the ratio basically of the peripheral ACTH to the ACTH that you're detecting in each of the IPSs. And here you can clearly see the incredibly high numbers in the right IPS. So this is almost certainly a tumor in the right side of the pituitary gland. And this is the time course. So you take sequential measurements after giving that medication, and the cutoffs are typically a central to peripheral ratio of over 3, and oftentimes they're much higher than that. Some people also use like a basal ratio without even giving the desmopressin or corticotropin releasing hormone, and that cutoff is lower, 1.4. High sensitivity and specificity, and obviously super useful for preoperatively. So we've gone through a bunch of different venous pathologies, and I hope I've convinced you that the veins are indeed as interesting as the arteries when it comes to angiography. And like I said, this does coincide and cross paths with a lot of different areas of neurosurgery. So I hope this has been informative for everyone. Thanks.
Nice talk, Mike. I enjoyed it. My only question is, the venous side of complication rate with access to these, kind of deep venous structures and, doing these thrombectomies, I imagine it's higher than using the typical arterial side, right? Can you comment on that experience with complications?
You're saying the complication for thrombectomy, you said?
Yeah, I guess a venous thrombectomy or even just access to like small microstructured venous microstructures, like are they higher than when you typically go on the arterial side?
I mean, I think it's hard to compare. I mean, they're very different pathologies, whether it's a M1 occlusion or a suprasagittal sinus thrombosis, or whether it's even for fistulas, right? Many fistulas you can treat transvenously or transarterially, and it's kind of balancing what's best. I think it's hard to have a direct comparison. If you're talking about specifically about access complications, like accessing the veins and arteries, I don't, I think it's obviously a venous injury is going to be less, for instance, in the leg is typically going to be less worrisome than an arterial injury and like a retroperitoneal hematoma. But I think it's hard to directly compare them, and sometimes and like I said, for instance, fistulas, you choose whatever is best for treating the fistula, whether it's transvenous or transarterial, and the access side is typically less of a concern, I would say.
Great talk, Mike. I think this highlights like the importance. Not only you spoke about particular examples of how different interventions are used, but also just observing the venous anatomy when you have like especially skull-based tumors, the venous anatomy can be sharply different. A lot of the times these tumors are slow growing. And so you're going to have changes in venous anatomy to sort of adapt to the tumor, and just understanding what you're getting into and how this venous anatomy can change is actually so critical for skull-based pathology. And oftentimes, you've seen me, I get some of these, and particularly ask you guys to go through the venous phase slowly, because it makes all the difference in the world for our surgical planning. So this is a really great talk, and in my opinion, a super important topic as well.
Yeah, great talk, Mike. Just in reference to the complications, another thing that's really important to think about that Mike highlighted is, are the veins in the dura and tacked down? Because those are a lot more difficult to injure, surgically, or when you're accessing them endovascularly, versus those that are deep veins like the basal vein or Rosenthal. Those are obviously a lot easier to damage and cause problems with.
Great talk, Mike. Just there's a lot of new data coming out with IAH. You kind of alluded to this idea that the gradient may not be as important as we thought for predicting outcomes. I just want to know if you could comment maybe why you think that may be. Is it because the overall pressure of the head is already so high? And then also, what is it about, what are the limits for kind of sagittal sinus stenting, as far as like the size and the length of stenosis that is able to be treated these days?
in terms of transverse sinus stenting, yeah, I mean, the anatomic considerations are important. We just had a case yesterday, trying to figure out whether even just the tortuosity of the sigmoid sinus, these are very large stents, and the catheters needed to bring up those stents are very large and stiff. And so even if there's a clear gradient, clear stenosis, great candidate clinically for a stent, sometimes just anatomically, it's not feasible, not possible. These patients also have to be after the stent on aspirin Plavix, so that's something to keep in mind as well. And then in terms of the low pressure gradient data, it does seem like even in the absence of a large gradient, there does seem to be a benefit. And I think it's exactly that. The pressures are so high that even if it's not reflected in a large gradient, that augmenting the venous drainage in any way can be helpful. So it'll be interesting to see where that data goes and who we end up considering good candidates for venous stenting.
Yeah, Mike, I think that's a great question, and it's unfortunate that that hasn't been worked out better. We did one of the first prospective trials in like 2012, 2013. And since then, there's been mostly just retrospective data, and a lot of it is sort of quote unquote subjective patient improvement rather than looking at papilledema, OCT, visual acuity, and visual fields. Generally speaking, at least in my patients, we like to see elevated intracranial pressure and a significant gradient. And so for me, that's usually ICPs, in the 30s or above 30s or 40s with a significant gradient, which usually is, more than 10 to 20. The group at Hopkins has been publishing on like low gradients and low pressure stenting. And I don't know that it's really that clear what they're treating. And I think outside of a prospective trial with adjudicated ophthalmologic follow-up, I think that's fairly risky and doesn't really benefit a lot of the patients.
Great. Thanks, Bobby. One more question on that. What is the kind of the ideal patient for stenting that you would recommend stenting over shunting or optic nerve sheath fenestration? Is it, obviously they have to have stenosis, but is it an age, BMI, comorbidities? Like, does it matter?
Yeah, I think that's great. Those are all great questions. And I think, we ideally we'd have better data to guide that. Generally speaking, the pluses and minuses. The plus of the stent is that it's minimally invasive. Patient gets stuck in the arm and the leg, and they go home the next day. The downside is they require aspirin for life and usually Plavix for 3 to 6 months. And you've got to compare that to the shunt. The shunts actually have really high failure rates, especially in these patients with small ventricles. On top of that, they can often have significant abdominal pressure, so they have problems with the distal end of the catheter. And I think all of us have managed these sort of disaster patients. A lot of times I see the patient after they've already had 10 to 20 revisions of their shunts. And, they're like, I am no way I'm going through that again. So I think it's a little bit of a balance of factors and patient and disease factors. For me, I would much rather have a stent than a shunt, just looking at the long-term failure rates of shunts. But I think it comes down to, at the end of the day, a little bit of patient preference and referring doctor preference. A lot of the ophthalmology doctors have sort of specific inclinations, and I think it's important to at least consider that. Although, as we've had more and more patients that receive venous stents over many years, and they see the complication rate is close to about 1%, they've kind of moved in that direction as well. So I think at the end of the day, if they have high pressures and a high gradient, me personally, I would much rather have a stent. But I go through all of those things with the patients before we get to that. The last thing about optic nerve fenestration is that can improve their eye symptoms, but it doesn't do anything for their intracranial pressures. And so those patients, may have some improvement in papilledema. But generally speaking, if they have high intracranial pressures, they don't do well. They have progressive, severe, debilitating headaches, tinnitus, imbalance. They get a quote unquote brain fog. And I think that's where, we got to be a little bit more careful about which patients we select.
Great talk, Mike. I think we're gonna have to cut off the questions now because we've got other speakers. So we've got Minor Mendez Valdez up next.
Can everybody hear me?
Yes.
We can hear you.
Yes.
So I'll share my screen here. Okay, so good morning, everybody. My name is Minor Mendez. I am a medical student here at UM, and I'm currently on the sub-I rotation. Happy to present some of the work that we've done in the lab with Dr. Shaw, looking at the intersection of GBM, HIV, and highly active antiretroviral therapy. And so I'd like to start just by really highlighting the impact that these medications have had on people living with HIV. The very first reported case of pneumocystis pneumonia and Kaposi sarcoma was in 1981. And by the end of the year, 337 people had been reported to have HIV, and approximately 40% of them had already passed away within 6 months of diagnosis. It wasn't until 87 that the FDA approved the first antiretroviral medication for the treatment of HIV. However, throughout these years, people of all walks of life have been strongly affected by HIV. Rock Hudson was the first public figure to disclose his diagnosis, and perhaps more familiar to most of us, Magic Johnson in 1991 disclosed his diagnosis, and approximately 2 weeks later, Freddie Mercury passed away from an age-related malignancy or age-related illness. And it really wasn't until 1995 that the era of highly active antiretroviral therapy really started to take off with the approval of the first protease inhibitor. By 1996, AIDS was no longer the leading cause of death for young Americans, and really by 1997 was when it became the standard of care for patients living with HIV. And these benefits continued throughout the following years. As you can see here in the top left, patients living with HIV have been living longer than ever before, and they're now living into their 50s and 60s and beyond. Following here in this top right panel, you can see that throughout this timeline, the incidence of age-related malignancies has actually decreased dramatically in these patients. However, during the same time frame, the incidence of non-age-related malignancies have continued to increase. And again, patients are now living with these malignancies into their 60s, 70s, and 80s. So when we, this other study in 2002 again highlighted this, and you can see here that of these non-age related malignancies, CNS cancer was actually significantly increased in this patient cohort. So when we looked at the correlation and the relationship between these two conditions, we saw that there was an apparent inverse relationship, with Eastern and Southern Africa having the highest incidence of HIV globally with the lowest incidence of CNS malignancies. In contrast, Western and Central Europe had the highest rate of CNS malignancies with some of the lowest of HIV. And there are many factors that contribute to this, and mainly the increased life expectancy in Western and Central Europe plays a large role in this apparent correlation. And so really the first part and the first question that we had was we wanted to better understand the implications that HIV had on GBM pathophysiology and oncogenesis. And so we began by systematically reviewing the literature and found a total of 24 patients that have been reported to have concomitant HIV and GBM. When we analyzed the data, we found that the median age at diagnosis was 39 years of age in this patient cohort, and the time to GBM diagnosis from HIV was 4.5 years. And importantly, this median age is significantly lower than the expected age of GBM, isolated GBM, between 60 to 80 years of age in the rest of the population. When we analyze the survival and the outcomes of these patients, we see that they have a significantly reduced survival of 8 months compared to TCGA, age, and treatment matched cohorts, which these patients had a mean overall survival of about 14 to 15 months, which is in line with that reported by Dr. Stoop in the famous 2005 study. When we continue to look at this data, we found that radiation tended to improve outcomes, although this wasn't significant. And patients that were given antiretroviral therapy seemed to do much better. However, due to the limited number of patients, we decided to explore this further. So the next objective was to investigate the role of highly active antiretroviral therapy as a potential therapeutic agent for GBM. And so far to date, there have only been 2 clinical trials that have been reported on using antiretrovirals for the treatment of GBM. And since then, there has been no further studies done. And so we began by trying to look at 16 medications and 40 different cell lines using the DepMap online portal. And here on the left circle, you can see that these medications tend to work and have an inhibitory effect on a similar population of established GBM cell lines, while other medications here in this orange red seem to work on completely different cell lines. And over here on the right, when we tested these cell lines and we analyzed the data in terms of how these medications inhibit these different cell lines, we found that abacavir, efavirenz, and ritonavir seem to have the widest range of inhibitory effect on these cell lines. And so we decided to further explore this in vitro in the lab. So etravirine, of these 4 medications that we tested, etravirine seemed to have the greatest effect on inhibitory effect on these cells, and it seemed to achieve it at the lowest possible concentration. While these other medications also seem to have inhibitory effects to varying degrees, they did it at higher concentrations. And so we decided to focus on etravirine for the following studies. And so here we took 2 patient-derived neurospheres, and we tested the effect of etravirine on different markers of stemness, OX4 and HERV-K, which is a retroviral marker of stemness. And both of these markers, a reduction in these markers has been associated with improved survival in these patients. And so I hope you can see here that after treatment with these medications, etravirine, there is a reduction in the expression of these markers. And we quantified it here with the Western blot, as you can see circled in red. And we also looked at the levels of reverse transcriptase with these medications. And we can see here that in both the patient-derived GBM43 and 28, there was a significant reduction in reverse transcriptase. The cell line A172 is notorious for being deficient of retroviral elements, which could partially explain why the levels actually went up in this case. And so we continued on this trend, and we tried to, again, look at the expression of markers of stemness, OX4, and in this case, Vimentin, by testing different antiretroviral medications on the established cell lines A172 and U87. And again, I hope you can appreciate here that there is a reduction in the expression of these markers across the board. And here we decided to quantify that data, and you can see that there is a significant reduction in OX4 and Vimentin in both the A172 and the U87 cell lines. And over here in panel B and D, we see that there is a reduction in cell proliferation in these cells as well after the treatment with these medications. So some of the limitations of the study include that there's a limited number of patients that have been reported in the literature with concomitant HIV and GBM. And due to this, there may be a significant prognostic indicator of survival that has not yet been identified. Again, as we touched on before, the advanced age in certain parts of the world and limited diagnostic imaging modalities, as well as the availability of neurosurgeons, could contribute to this seemingly contrasting correlation between HIV and GBM. And finally, our in vitro work was limited to a small subset of cell lines, which means that it may not be representative of the entire data. So in conclusion, the overall survival in this patient population is significantly less than in that of patients with isolated GBM. Treatment with antiretroviral therapy and chemoradiation tended to improve survival in these patients. And there may be a role for antiretroviral repurposing as a novel agent for patients with GBM. And following with this, future directions, there should be more detailed and exhaustive records when coming across patients with these 2 conditions, as it could lead to improved outcomes in these patients. Systematic studies are needed to better characterize the outcomes in these patients, and the HIV and Cancer Match study could be a potential avenue for such work. And very excitingly here at the university, Dr. Shah will be beginning a clinical trial looking at the treatment using antiretroviral medications in patients with newly diagnosed GBM that are going to be treated with laser interstitial thermal therapy. And very fitting, the Starlight trial. This is a picture of the Starlight Hotel here in Miami Beach. And so with that, I would like to thank Dr. Shah and the rest of the SVI lab for their help on this project. Acknowledge our funding sources and our collaborators at the NIH. Thank you very much, and open to any questions.
Great talk, Minor. Congratulations on the paper that got accepted to Journal of Neuro-Oncology, and of course the work that you've done in the lab. And we're excited to kind of move this forward to clinical trials. And I think this is kind of a great analysis how you can take a clinical question and bring it to the lab, and then bring it back to the clinic. So good work overall.
Minor, great job. I'm not too familiar with the antiviral HIV therapies, but the drugs you tried on the patient-derived cells, are they combination therapies, or are they like just specific therapies? And if they're single therapies, did you try like the combination therapies that are combined with like heart therapy for HIV?
Yeah, great question. So in the lab, we only tried isolation therapy. We have not done any combination therapies yet, although that is definitely a good point that we could further explore. The reason why we haven't done it is simply just like a starting out. We wanted to see if there was any effect. And now that, there is some preliminary data, I think it would definitely be a potential, a good idea to explore combination therapy as it is done in patients living with HIV.
Very good. We're going to have to cut it off there and go on to Krishna now. Thank you.
Hi, good morning. Can everyone hear and see my screen?
Yes.
We can see the screen and we can see the presentation.
Awesome. Well, good morning, everyone. My name is Krista Maddie. I am a fourth-year medical student here at the University of Miami, also doing my sub-I. And I'm grateful for the opportunity to present my project titled Influence of Instrumentation Type on Outcomes After Surgical Management of Spondylodiscitis. So spondylodiscitis represents primary infection of the intervertebral disc with secondary infection of our neighboring vertebral bodies. Management typically involves a course of antibiotics as well as surgical debridement of the affected segment. But in patients presenting with intractable pain, neurological deficits, evidence of spinal instability, surgical stabilization surgery is often required. However, there are no clear guidelines in the literature about how to approach these patients. And typically that stabilization surgery requires placement of a structural graft to improve stability, avoid pseudoarthrosis and kyphotic malpositioning. But again, there are conflicting recommendations on the optimal cage material type to be used in these patients. And currently in use are allograft, autologous bone graft, titanium cages, and more recently, the polyethylene ketone cage. So what we were interested in understanding is what material type is preferred in these patients in order to optimize their outcomes after surgery. This is just an example of an institutional case here done by Dr. Shelby Burks in a patient with L2, L3 spondylodiscitis who was managed with placement of a titanium cage and had great improvements neurologically and pain-wise post-operatively. So how do we understand which cage material type is most important and vital in these patients? So we started by conducting a systematic review and meta-analysis of the literature. Our initial search yielded about 2,100 articles. And after a series of inclusion and exclusion criteria, we included 35 studies in our final qualitative and quantitative meta-analysis. And these studies were mostly retrospective single-arm studies across the 4 different cage material types, including PEEK, titanium, allograft, and autologous bone graft. And we conducted a series of pooled descriptive analysis, and we ended up with a cohort of about a little over 1,000 patients across these 4 different material types. And we looked at a few different outcomes of interest, radiographic fusion, screw loosening, as well as need for surgical revision, and collected a number of clinical and radiographic variables from the studies. And interestingly, bradifussion being the most relevant for surgical correction, allograft had the reported highest rate of fusion. So on further statistical analysis, we wanted to take into account the effect size and the heterogeneity of the reported clinical information of each of these studies. And so we performed a meta-analysis of proportions and looked at these 35 different studies across the different instrumentation material type groups in order to look at these variables of interest and examine for statistical significance. And we found that there was no statistically significant difference in radiographic fusion across the 4 different instrumentation types. We also looked at rate of reoperation and again found no statistical difference across the 4 different instrumentation types. And we looked at screw loosening and again found no statistically significant difference across the 4 different instrumentation material types. And so we concluded from our initial review and meta-analysis of these 35 studies is that there is no difference in the choice of instrumentation type on the clinical and radiological outcomes of interest, being rate of fusion, screw loosening, and rate of reoperation. However, from our review, there are a few different significant considerations that we should consider. First being biofilm formation, which is going to be the biggest fear when we're introducing foreign material into a patient with already existing infection. Interestingly, Kregitz et al. Showed that there's an increased presence of biofilm formation associated with peak cages in particular. And even further than that, certain material types can be associated with higher rate of growth with certain organisms. So they reported that peak is going to be more susceptible to some of our staph species, including Staph epidermidis, MRSA, and MSSA. And they found that titanium is going to be more susceptible to biofilm formation with E. coli organisms. And so understanding that these different cage material types can be associated with more susceptibility to biofilm formation with certain particular organisms is helpful given that all of these patients get cultures. And so understanding what bug they have and which material type might be more beneficial to them post-operatively for their improved outcomes is going to be vital. Additionally, we found that screw loosening, there were some conflicting results as well. A couple of studies reported that there was higher rates of screw loosening that occurred with the placement of PEEK cages compared to others. In our own study, we found that PEEK had the highest rate of screw loosening at 8% compared to titanium's 0.3%. However, this was not statistically significant. This difference wasn't statistically significant when we took into account the effect sizes of those studies. But again, this emphasizes that there's a need for comparative studies because these were all single arm studies that reported a higher rate of screw loosening associated with PEEK cage material. And so that's what we're trying to do now. So I'm happy to say that meta-analysis and review has been submitted and is under review for publication. And what we're doing now is we have a cohort of about 58 patients across 3 different University of Miami spine neurosurgery attendings. And we're collecting a lot of different clinical and radiological variables to look at lordotic and kyphotic correction after surgical management with fusion and instrumentation, rate of reinfection, surgical revision, screw loosening, rate of fusion, as well as changes and improvements in neurological deficits, as well as pain postoperatively, with the eventual goal of creating a multi-center study to control for instrumentation type in patients who require surgical stabilization for spondylodiscitis, looking at these patients for a couple of years and reporting on those outcomes. And especially in vulnerable populations like our patient population here in Miami, this work is especially relevant to understanding what factors might be most important to consider, including instrumentation type as part of that algorithm, with the ultimate eventual goal of creating a standardized guideline for the surgical management of spondylodiscitis, which doesn't currently exist in the literature. And really, this work highlights from our review that there's a need for evidence-based decision aids. And in the past couple of years, there's been a little bit of a focus on how do we surgically manage patients with spinal infections. One study that we found created a proof of concept study called the SITE, so Spinal Infection Treatment Evaluation Score by the group by Plummer et al. And they created this decision aid that allows you to decide if a patient should or should not be taken to surgery for management of their spinal infection, taking into account location, radiological imaging, their neurological deficits, pain, as well as a host of other comorbidities. However, this is just the initial decision aid. We still don't have the sort of next step. How do you decide once you go into surgery? What are the most important variables that are going to help you improve and idealize the best patient outcomes here? And so the major takeaways of our study is that this highlights the need for future comparative studies to create an optimized evidence-based guideline for surgical management of spondylolischitis. And the literature is clearly very limited to look at the different types of instrumentation and materials of those cages, given that there are no comparative studies that are being done. These are all single arm studies, but there are some special considerations with screw loosening, with biofilm formation, that could be very vital information. So how do we start by one, understanding what's currently in the literature with some of the systematic review and meta-analysis data that I presented, taking that next step, carrying out that retrospective study, and then carrying out future studies to contribute to the creation of an evidence-based guideline that incorporates instrumentation material type to improve the patient outcomes clinically and radiographically for these patients. And so I want to take a moment to acknowledge Dr. Shelby Burks, who was my primary mentor on this project, as well as Dr. Levy, Dr. Liu, and the rest of the members of the Burks and Spine Peripheral Lab for their help with this project. And thank you all of you for the opportunity to speak today. And I'll take any questions.
All right, well, thank you very much. Very good. Christian?
Yep, I'm ready, Dr. Ledney.
You're good.
Okay, good morning, everybody. I think I don't have much time, but I'll turn my speed up to 1.5 here. I talked really about chronic subdural hematomas. It's kind of like just a curiosity interest of mine. There's been a lot of work done recently, especially from the endovascular side, in advancing treatment strategies. So we'll talk about a lot of that and the kind of new research that's coming out, as well as kind of the older strategies that we've all kind of known, but there's a lot of evidence for supporting certain things and not others. So here's just quick examples of chronic subdural hematomas that get worse. You know, we start as an acute, maybe this isn't bothering a person, maybe we're not seeing a lot of neurologic deficits, but as it's progressing, it's causing more midline shift and becoming more symptomatic. They're fairly common. There's a high reoperation rate, and with the increased use of antiplatelets and anticoagulants, which seems to go up by the day, we're starting to see more and more of them as time goes on. The 1-year mortality is 4%, and the overall cure rate is 82%. I don't know about you, but that seems a little bit low for something that seems like a quote simple problem. This is really a problem as old as time. Here's some Peruvian skulls that have been trephined from 200 BC. There's multiple works of medieval art showing them doing trephinations. This one's from the 1500s. This one is from France, again in the 1500s, where they're showing different surgical procedures at the time, including bloodletting and I don't know, stabbing some guy in the leg and stuff, and amputations. But trephination for what was suspected to be subdural hematomas was one of those treatments. So it's a chronic problem, not to use a pun, for humanity. First described in the 1600s, and then the various reports from other people about what you could sort of put together as being a chronic subdural hematoma presentation. Eventually, Virchow described pachymeningitis hemorrhagica interna, which ultimately became what is known as chronic subdural hematoma by other physicians. The mechanism of why chronic subdural hematomas become a problem is you end up with an acute hemorrhage from traumatic injury. There's inflammation. Inflammation draws in macrophages and other cells that then release factors that cause angiogenic factors, which then cause these capillary formation that are poorly formed and they're leaking, and then you get more inflammation, and it's just this vicious cycle that just perpetuates itself, and then you get more growth of the subdural. The membrane formation is kind of the hallmark feature of the chronic subdural hematomas, and that's where the pathology really is, because they're vascular. They kind of weep these inflammatory markers and are sort of a self-fulfilling prophecy of subdural hematomas. Fibrinolysis is part of the problem, and then angiogenesis and these inflammatory markers, as I mentioned before. Here's a kind of visualization of what I was describing. You have this fibrin cascade and breakdown of the clot in the membrane that then activates these inflammatory markers, which then upregulate the angiogenic factors. And then you have this cycle that just seems to go on and on and on without an end. So the basic treatment strategies, which we kind of are all familiar with, generally either non-operative or surgical are kind of the big ones. But if you're going operative, the big one that usually gets asked, and this part of my talk is sort of inspired by one of our recent graduates who first forgot all this stuff and asked me all these questions. And so I had to remind him of all this stuff. But should you use a drain? Because that was the first thing he asked me. And this is probably has the most robust evidence. This is a multi-center trial. This is a randomized controlled trial. This was in Lancet. It was probably one of the best designed trials I think I've ever seen, where they drained the subdural, and right at the time of drainage, they said, okay, we're done with drainage. We're going to randomize them to drain or no drain. And the results are pretty remarkable. I mean, there's a huge difference in recurrence, mortality at 6 months, and then these sort of longer term outcomes are just remarkably better when you're using a drain. I mean, at 6 months, MRS 0 to 3, I mean, 84% compared to 71, and it's just a huge difference. There wasn't any difference in deficits or sort of the complications from using a drain either. This one's a systematic review. Again, same thing. There was no difference in mortality and morbidity, but the recurrence rate when using a drain was significantly less. And this is demonstrated in multiple trials. I'm just showing these two big ones, but it's a fairly robust result. Again, same thing. This one's another systematic review showing the same thing. Different people use different types of drains. I'm not talking about like the brand or the type of drain itself, but the placement of the drain. I know some attendings here use different ones. That being either subdural drain or subperiosteal drain, with leaving the dura open to drain outside the skull. I think most people use subdural drains here, but there are a few attendings who are using subperiosteal drains. So this was a study where they did both. It was chosen preoperatively. You can see kind of where the drains were placed. They didn't really see a difference in the two drains. They did have a lower mortality in the subperiosteal drain, which is why they recommended it. But if you look at the rate of recurrence, the subdural drain actually does have a lower rate of recurrence than the subperiosteal drain, although that was not statistically significant. And then the next person our recent graduate asked is, well, should I do burr holes or should I do a craniotomy? And here's a study I like a lot, that they had 3 treatment groups. They had a single burr hole, a 2 burr hole, and then a small craniotomy. So basically it was, if you look at area, it's going up from 10 millimeters, 20 millimeters, 30 millimeters of boning removal. And all of them received subdural drains. You can kind of see examples of what they were doing. They saw big differences between the 1 burr hole and the craniotomy, but not a lot of differences between 2 burr holes and craniotomy over a variety of factors: hospital length of stay, revision rate. Craniotomy and 2 burr holes were essentially equal. The only thing is, when they compared them and they put 1 and 2 burr holes together and you compare those against craniotomy was significantly more effective and had less problems than just doing burr holes. Same thing. This is for opening the inner membrane. Again, highly effective. This is some other stuff that people tried using head of bed flat. I mean, some people do it here, some people don't. I think it's a fairly common tactic to get the brain to re-expand and essentially push out the subdural out of the drain that's there. But there, again, no difference was seen between the two, but there was a pretty significant selection bias, and it was all very small studies. So there was also no control of what kind of surgery they were doing. This is another systematic review. Same thing, positioning didn't really show any difference in effectiveness. They tried irrigation, same thing, and this is the same systematic review. There was really no difference whether you used irrigation or not, which I know, depending on the attending, we spent a lot of time irrigating the subdural fluid out. Here's another one, TXA, that some attendings use, other ones don't. This was a randomized controlled trial. Half and half got TXA, half of them just got standard management. They did report a higher recurrence rate with the TXA, but the number of patients was fairly low. So I'm not sure if this was really powered appropriately to make a call on that. They did see higher complication rate with TXA. Again, that the power wasn't quite there, but I think the important thing is that maybe there really wasn't much of a difference. Although a larger trial would probably be better to look at that. And then because of the, all these studies saying, oh, the drain is what is the driving force of the subdural hematoma, bedside drainage has become a thing. I think we've started doing this a little bit at Jackson. We did one while I was on cranial a couple of months ago. This is a SEPS drain. It's basically a bedside burr hole drainage. You put this bolt in and connect it to what's basically a JP and leave it there. It's really reserved for patients who are kind of too sick to move. They've got a lot of comorbidities, the kind of person that may not tolerate being wheeled to the operating room, or maybe you don't want to wheel into the operating room. And this study tried to show that they were basically the same as doing burr hole drainage. It was sponsored by Medtronic. There was a heavy selection bias because a lot of these patients are fairly sick. So I don't know if that's really true or not, but yeah, I think it's a useful tool in the right patient, depending on what your needs are. So that's kind of the basic treatment strategies that we all know. And I'm not an endovascular person like Mike Silva is, and he touched on some of this stuff during his talk. But embolization is kind of the future of subdural hematomas. Either that's with or without surgical drainage. I think there's a role for both. But endovascular treatments really are kind of the future of chronic subdural hematoma management. In the 2000s, there was a study that kind of looked at this, why these were occurring, and Mandai et al. Was the first one to really report embolization of the MMA and as treatment for subdural hematoma. But it wasn't really until very recently that this study, which was in Journal of Radiology, was published. And this is 2018, so it's within my residency time. They had a group of patients, some of whom were what were called asymptomatic, meaning they don't have a significant neurologic deficit. So they basically are just saying they have a drift and that's it, or they have a headache, but they don't have altered sensorium, they don't have cranial nerve deficits, they don't have like hemiplegia, stuff like that. Those are considered symptomatic patients. And of the 27 asymptomatic patients, there was 100% resolution of the chronic subdural hematoma. And only one of the symptomatic patients, again, somebody with a severe neurologic deficit, altered sensorium, there was only one that required, that had treatment failure, which would be reoperation, et cetera. All of the symptomatic patients did receive surgical drainage as well, but only one of them had a recurrence. So very robust results, and this has launched kind of a whole new wave of research into these kind of treatment strategies. And you see here, starting in 2018, where things really just took off with these minimal meningeal artery embolization publications. It's gone up by 6x. Now we're starting to see a maturation of the research. So now we're seeing this is a systematic review that is kind of published out of print. 14 trials included. Now people are kind of have migrated, seems like, to the embolic agents. And this is just the breakdown of what was used in these trials. The recurrence rate's 3%. The rate of needing additional surgery is 4%. And these are people who are what fall into the asymptomatic group. So it's people that have headaches or just a drift. And very robust results. If you recall, like the kind of historical data is like for 15% recurrence rate. So we're talking a huge increase in the success. This is a newer trial. This one I think is from 2021. Again, it's the same thing. It's people who are quote asymptomatic or have mild symptoms. Multi-center trial, and the rate of needing of failure is only 6.8%. So the rate of radiographic failure is a little higher, but I think that's just a factor of how soon they were scanning people as being part of the study. So if you're getting somebody a CT scan at 2 weeks, I believe that the subdural is probably still going to be there. They also noted predictors of failure, which would be someone who's on anticoagulants, which you might expect, and then also a small MMA. They also found that liquid embolic agents were more effective than doing coil embolizations, because some centers were doing purely coil embolizations in that study. And right now there's a lot of ongoing studies in various places using different embolic agents. There's these 3 here in the United States, and then there's another one in China using different embolics, but all basically trying to do the same thing because of the results from all of these studies. And this is sort of a sign of how this has matured to the point where, because this is so effective, we're seeing people trying to reverse engineer the results by not who maybe don't have access to angiosuite or embolization technology. So this is a study that's sort of done out of Sweden, I think, but some of the authors are neurosurgeons in, I think, Rwanda and Jordan, who don't have a population or the ability to do these sorts of maneuvers. So they're trying to replicate the results of minimal artery embolization by doing direct cut downs on the MMA, which I'm not supporting this strategy, but just it's an interesting kind of occurrence that they're trying to replicate the same thing without the technology available. So they did a series of cadaver skull dissections and analysis, and they basically came up with a way to target the MMA based on anatomic landmarks, which they've published here as the mean distances between these lines between the EAM, the frontal zygomatic suture, stuff like that. They also, depending, the interesting thing about the study is they had essentially different levels of how much technology you had, whether you had a CT scan or whether you had frameless neuronavigation, in order to treat these things without endovascular support. So this is the way that they were able to localize which branch of the MMA was feeding the subdural or suspected to feed the subdural, and they've reported their results here. It's sort of a game of trigonometry. And then here's their cadaver analysis, where it was essentially like a proof of concept where they would try to do cut downs and get to the MMA. They even talk about the risk of frontalis palsy. I think in the environments in which this would be appropriate, maybe that is seen as an acceptable risk versus coma from subdural if you don't have endovascular support. But I'm not sure that this would be acceptable in the United States just due to the pure risk of it. And then here they showed the same, that they could do the same things that they were demonstrating with the measurements with frameless stereotaxy for those of us that have that available, but maybe you're in a more rural area and you don't have an angio suite and the ability to do embolizations. And that's my talk. I tried to go quickly so we could get done in time. If anyone has any questions, I just want to thank Dr. Stark for emailing me and kind of going through some of the newer research.
Great job, Christian. I know you mentioned about the bedside drainage and how it's hard to analyze that study because the patients were so sick, but I'm pretty sure I hear from my Canadian colleagues that, since there's no operative time at all, that they do even their healthy patients at the bedside. So it might be interesting to see the Canadian experience with that. I think very rarely do they actually go to the OR, and proving that it would be safe and effective to do it at the bedside might be something to consider.
Yeah, I think we have a series of fellows who, depending on where they are, do it a lot. It seems like. So I don't know if it's at other centers. It's just a very common thing.
Yeah, we actually used to use it a lot in New York for, depending on the patient, but healthy patients as well. The nice thing is you essentially do it under local for, the sicker patients that you don't want to sedate. And if they're a little bit more awake, you can give them a little bit of sedation. The complication really is at some point, if you do it enough, somebody's going to plunge. versus also sometimes you enter it right at the location of like a membrane, and then it bleeds and it can form and turns into an acute subdural. The bedside drainage really only works if it's nice and liquefied, so you have to wait till it becomes more chronic. And if there's membranes, you sort of have to be very strategic in where you place it. Sometimes it takes more than one, but we used to use it quite frequently and with good success rates. And then we actually used to combine it independent, like we would do lower extremity Dopplers, determine whether or not they had any DVTs or any other contraindications for TXA. If they didn't have any contraindications for TXA, you can just drain off some fluid to get the pressure off, relieve the symptoms, and then use TXA for resolution of the subdural, and it worked very nicely.
Christian, great talk.
Yeah,
I just wanted to ask one quick question on your review of the MMA with surgery.
Mhm.
You know, it seems like a lot of times we do surgery and then MMA happens at some convenient time afterwards. But I didn't know if it was hard for me to understand. It seemed like some people were getting MMA embolization and then taking the surgery, like almost the same day, or what was the kind of the practice that was in those studies?
No, if you're talking about this one, it was they right off the bat divided everybody up into symptomatic or not symptomatic, and again, that's basically like someone who's got mild symptoms or someone who's got severe extremis type symptoms. Those people got surgery up front, then followed by MMA embolization. Then
what was the generalized consensus for the timing of the MMA embolization?
I don't know. I don't think that was control for it. I'm not sure. I have to look into that. I'm not sure. I didn't see ones where they did MMA embolization first and then did craniotomies. Because these people being in extremis, but two, the people that they would fall under treatment failure. That's how they were measuring treatment failure in a lot of cases. So I think that's how that was measured. So I'd have to look at the timing.
Got it. For most of the trials, it's within 24 to 36 hours of the surgery. I mean, there is some theoretical benefit from doing the MMA embolization first. You know, in an ideal situation, we'd like to give these patients at least a low dose of heparin, which could be reversed at the end of the procedure, and then the patient goes right to the OR. Versus if you do it after the surgery, you know, sometimes these patients still have drains in place and this and that. So we routinely do it, you know, immediately after surgery or a day after surgery. But I don't think there's been really a clear consensus on what's the most optimal situation there. Thanks, Bobby.
Chris, great talk.
Thanks.
Just about the bedside drainage again. So the SEPS is a great alternative, as Carolina was mentioning. One problem would be maybe that that bolt is sticking out. If the patients are moving, they could hurt themselves or so. But it's good. What we did in a few patients that were too sick to go to the OR, they had large hematomas, they were symptomatic. We implanted at bedside like the cerebral flow, which is the EVD catheter we use for hemoventricle. With good experience with that. That's maybe an alternative if SEPS is not available or undesired. We even used the stealth in one case. It worked well at bedside.
I agree. We really need to get that. We have it at South and I think at North, but for some reason we still don't have it at Maine. We really need to get that. Maybe Joe, me, and Carolina could write a paper or write a letter, just email and get that in here. It's better than having our fellow keep driving back and forth with the SEPS, bringing it up from South.
Yeah, for sure. I agree with that, Mike.
Yep.
Okay, well, thank you, everybody. Appreciate the comments.